This is Marie-Chantal from Tinnitus Therapy Online, clinical audiologist and tinnitus specialist. In this video, I explain how trauma or traumatic experiences in your life may have an influence on the severity or indeed the actual onset of your tinnitus. Mind you, I emphasize this is for cases whereby no hearing loss or ear health issues are present and your MRI is also clear. I'm looking specifically at how we can reduce the overall stress held within your mind and your body, because stress is a large driving force of chronic tinnitus. Trauma, as you can imagine, causes significant stress within the mind and subsequently the body. In fact, post-traumatic stress disorder, otherwise known as PTSD, is in essence a chronic stress cycle that must be addressed, especially if you have tinnitus, if you wish to in fact manage your tinnitus better. Here I speak to Heather Cuffe, EMDR practitioner, CBT psychotherapist, and the trauma clinical lead for the NHS Trust. Heather answers my questions about EMDR, a type of trauma therapy that works to heal stored trauma within the mind and the body and works to reduce overall psychological and somatic stress. This was an impromptu conversation I had on a weekend out of my own curiosity about how I could source the best solutions and knowledge for those clients who come to me with a significant history of trauma. In these cases, I refer out to specialists who can treat this side of the patient while I work on my area of expertise in collaboration. We decided to publish this video as it was too interesting not to, and also with the intention of helping others like yourself out there. I should mention I do not endorse specific methods per se. Instead, I use a multimodality approach and tailor my treatment of tinnitus according to the individual at hand. It really does depend on what the patient brings to the table, their medical, psychological, and physical history, as to where I will go with their recovery plan. Everyone is different, and as such, treatment plans are also different. However, for those of you with a significant history of trauma, this video will definitely get you thinking, and this one's for you. It is certainly something you might like to consider. Thanks for watching.
So it stands for eye movement desensitization and reprocessing.
Yes.
It doesn't quite now, I think EMDR has moved on a bit and developed.
Yeah.
And perhaps something more about reprocessing and desensitization would kind of fit better.
Okay.
Because the eye movement part that it's become known as, where the eye, during part of the therapy, it's just a part of the therapy, where the client has helped move the eyes from side to side whilst they're processing or sort of working on a target memory. Mm-hmm. The idea of that is it activates the memory network. We do that naturally during REM sleep, rapid eye movement sleep,
yes,
when we're processing the day's events. And also, because they're doing that, they have like a dual attention awareness. It's taxing working memory. They have a thought in the past in the memory about what's happened, but they're doing it from the perspective of the age and the time and the safety they're in now. Mm-hmm. And with the therapist doing that work. So they have this nice dual attention awareness. So whilst they have to revisit the event to perhaps release the pain, they're doing it from some safety of the present. So it's distressing, but not re-traumatizing.
Okay. I'm curious as to how it actually works.
It's been around since the 1980s.
Okay.
There's been lots of research on it. It's recognised in the NICE guidelines, National Institute for Clinical Excellence.
That's really good, because that's what I was curious about, whether it is a recognised form.
Yeah, the World Health Organization.
Okay, great. Because EMDR, so my understanding is that it is really quite effective in a quick way. So the time frame of the therapy sessions is condensed for people with trauma. So if someone had a traumatic event or maybe sustained type of chronic distress, which they had PTSD over with time, that if talk therapy was exacerbating those symptoms, or perhaps they just weren't getting anywhere with releasing that trauma, then EMDR would be quite an effective type of method. Is that right?
So I suppose we have to understand what trauma is.
Yes.
Because So if we take perhaps a simple case of a road traffic accident, and most people would sort of, process that naturally. So over the days or the weeks after the accident, they may dream about it. They may talk to their friends and family about it. They may get upset about it. They will hopefully be supported through it. And it may be that if there's been sort of very little, other related trauma, most people work their way through it and process it naturally. The body has that, the brain and the body has that ability. Traumatic events happen in our life. We have series of minor injuries, minor woundings, humiliations, embarrassment. We often work through them, and we come to an adaptive resolution. In the case of a car crash, I'm safe now. In the case of a friendship perhaps gone wrong, I am likeable, it wasn't my fault, I learned something from this. Okay, so we can often process this stuff by ourselves and with the help of family and friends. But sometimes a trauma gets stuck. It gets kind of stuck in the body. The experience isn't properly processed. And that might be because there's lots of other prior trauma. It may be they shut down and don't talk about it. They don't want to think about it. They want to try and put it in the past. It may be they don't really have people around them they can process that with. It may be they get messages from people, oh, well, it's not happening now, forget about it, move on. So these traumas can get stuck, and we can feel that, maybe that shock in our body, and it kind of gets trapped. And then we can develop beliefs about it, or beliefs that we had at the time remain, such as I'm not safe, I'm in danger, I'm vulnerable, thinking particularly about a car crash, I have no choice or control, or it's my fault, I'm responsible. So our assumptive world is shattered, really. We no longer believe we're safe. We no longer believe we're safe from blame. We constantly feel we're vulnerable or in danger.
How do you determine the difference between someone that has this clinical trauma versus someone that's just got the natural rhythm of grief, or anxiety as a side effect, but that's just a transitional experience or transitional depression? How do you know this is a traumatic issue stuck in the body, it needs to be released because you've got all of these other symptoms being sprung off from it?
Yeah. So often there's an event, there's a traumatic event, and often the psychometric measures, there's obviously assessment and interview, and the main symptoms of a post-traumatic stress response would be the person has intrusions. So things like flashbacks. Flashbacks can be visual, they can be auditory, they can be emotional. We can reenact things, so they can be behavioural. So there may be flashback experiences, there may be intrusions, intrusive images, may intrude nightmares, kind of weird or bad dreams. Being hyper aroused, alert and on guard, watchful much of the time, and also a level of avoidance, avoiding perhaps getting back to driving, avoiding motorways in the case of a car crash, in the case of perhaps more interpersonal traumas, avoiding relationships or intimacy of relationships, avoiding talking about it, thinking about it. And then you end up with, you've got this level of avoidance, but it intrudes anyway.
Yes. Yeah.
Yeah. So, and then with that, you often have mood changes, sort of anxiety, low mood, perhaps panic, things like that. In the case of, say you mentioned about grief, there is a natural grief sort of bereavement process. But for some people, there's been a traumatic element to that. Perhaps the way in which their loved one died, perhaps medical negligence, perhaps suicide, perhaps the shock of finding the body or the state of that the body's in. So, and sometimes those, the normal trajectory of grief feels blocked. So it's not unusual for me to be working with a 40, 50, 60-year-old person who experienced a traumatic loss or bereavement that wasn't dealt with at the time, perhaps when they were a teenager, or a person who's found their parent has committed suicide.
It feels quite a beautifully simplistic way of treating trauma, which I think is why is it's so surprising. I just think, wow, you just have to follow someone's finger left to right and then think of your traumatic history. Is that all you need to do? This is a miracle. So tell me.
No, so it's an 8-phase protocol. It has 8 phases to it. Yeah. And it has 3 phases. So it kind of addresses the past, it addresses the event or the events that have occurred. And you can imagine in the case of childhood trauma, and then perhaps there may be additional adult trauma, that's an awful lot of material of maybe neglect, physical abuse, sexual abuse, things that were done, things that weren't done that should have been done. Okay, so the past is addressed and kind of processed, then all the current triggers and concerns, and then the future about how that person would like to be sort of maybe managing similar situations, in the future. So, for example, if they've had a trauma with a bullying father, process that. It may be they're constantly triggered, at work by their manager, and then it's thinking about working through how you'd like to be managing that, what you need going forward. Okay. So like any psychological therapy, there's the history taking phase, there's assessment, there's preparation and stabilisation, because you can't start working on this material until somebody, it can be in a window of tolerance. Now, for some clients, that preparation and stabilisation may just be a session or 2. There are some clients who perhaps never get out of that phase at the other extreme. So you can imagine that some of the adult clients in secondary care mental health services their risk is managed, their lifestyle is managed, their medication is managed. Okay, so there's not a lot of space there for them to be actually doing the work that has caused the distress and the disturbance in the first place, because they've developed maybe alcohol problems or drug problems or risky behaviours, or they remain in chaotic situations, chaotic families, domestic abuse, things like that. So for some people, they never quite get out of that sort of stabilisation and management. There's a whole group of people in between that. I work for a CAM service, and one of the treatments, the programmes offered is DBT, dialectical behaviour therapy. And you could say for those clients who have a prior trauma history, and I guess most of them will, DBT is an extreme form of stabilisation and preparation and resourcing. So I've had perhaps clients who have done that programme for a year, it's only then are they ready for EMDR.
Okay, so that's a really thorough type of preparation for EMDR.
Yeah.
Which is really, it's good to hear, because I thought it was just, you click your fingers and you think, okay, just think about this memory, left and right you go with your eyes. This is a brilliant and simplistic way of treating.
So done all the preparation and stabilisation, which is only phase 2, okay, and you're also having some idea about, you know, you've perhaps got a timeline, you're looking at, you're aware of what the main events, what's happened to this client, and what you want to work out is which of those events holds current distress and disturbance. There may be some that have been completely just naturally reprocessed. So you're looking at what the client wants to work on, what are their priorities. Standard protocol, we might work with the first, the worst and the rest, or the first, the worst and the most recent. But it may be the client has one in particular that just seems to be more bothersome or more current. So you have to also work out about which ones are perhaps have links or associations with each other, because when you're working in this way, you're activating the memory network, and there's all sorts of associations that aren't always obvious. Yeah. So if a client has a belief of I'm in danger and they're working on this car accident, have there been other events in their lives where perhaps that same core belief is present? Because it may then link to them, and you want to try and be prepared for that, because we don't want to re-traumatize them. We need to be holding them sort of in a frame. We need them to be within a window of tolerance, so it's not, we don't want to traumatize them through the trauma therapy.
Yeah, definitely. I suppose, do you actually explain the risks to patients? There is a slight risk of re-traumatization, I would imagine.
Well, that's what the preparation and the stabilization and the resourcing is for. So as the therapist, you're carefully attuned to the client. You're reading their body language, their breathing, you're stopping every maybe 30 seconds or so, you know, seeing how they are, what they get, what they notice. Okay, so you're doing this in a very safe and resourced way. Bilateral stimulation, the eye movements which replicate REM sleep, okay, across the 2 hemispheres of the brain, what we found out is it doesn't necessarily have to be eye movements, okay? It can be tapping, okay? And it can be audio tones, so beep, beep, beep in each ear. Yeah. So the tapping can be like this, it can be like this, you know, it can be like this. Okay, parents might do it on the children's shoulders when we're working with children. Okay, and we also have something now called theratappers, which are like little buzzers in each hand. Okay, or we might pop them down children's socks while they're drawing or listening to the narrative and wriggling around the room as they do.
That's great.
There's various ways of doing the bilateral stimulation, and when we're doing that, what we're trying to do is not only stimulate the memory network, activate that memory network, the client is working through it, but we're also very concerned with not only perhaps the images that the client is remembering and connecting to. We're interested in the emotional experience of that, what emotions are being felt and expressed. We feel the emotions in our body, so where are they feeling that in their body? Okay. So we're working with the body sensations as well. And we're also working with the beliefs that they've attached to that they've developed as a result of that. Beliefs that might be about, depending on the trauma, about sort of being flawed or defective in some way. Usual ones are, you know, I'm unworthy, I'm unlovable, I'm unlikable. I'm unimportant, I'm invisible, okay, I can't connect, those sort of things. There's beliefs of responsibility, you know, it's my fault. One's about choice and control. You know, I have no choice or control, perhaps for people who have been abused in some way. Okay. And ones of safety, you know, I'm vulnerable, I'm in danger. We see in EMDR, we see the body as we see the brain as a whole, as kind of a whole body brain. Yeah. Really, it takes in the heart and the guts, and the neuroscience is supporting that.
What was the go-to trauma therapy before EMDR?
Go-to trauma therapy, I would say, was trauma-focused CBT. But I think perhaps there are still people, non-directive counselling in the NICE guidelines is not recommended. So, you know, non-directive counselling is very good for some things. I often find that some people aren't very good at recognising PTSD. So I've certainly had clients come to me where the counselling has been a good experience on one level, but it's actually made the PTSD worse, and then they've come looking for sort of treatment for PTSD. But I think broadly counselling and CBT of what people have traditionally had.
Yeah. In a sentence, why are you choosing EMDR as your focal point, like in summary?
Okay. Because I think it treats the whole, it treats every layer, it goes in at a deep level. So it kind of deals with the whole brain, not just the cognitive brain, but it deals with the limbic area and the brainstem, and how trauma is held and expressed in the body, and then how that is kind of reenacted often in everyday life.
Is there anything else you recommend to your patients when they do EMDR with you? Do you have another supplement to that treatment?
You know, often some clients are they're into their sort of dorsal vagal kind of shut down flop. So for them, we might be looking about how they might in between sessions kind of activate that and be in that healthy social connection, that kind of ventral vagus nerve kind of space. So we might be looking with them about activities, you know, sort of walking, things like that. With the ones who are hyper aroused, the ones who are in their who are activated, okay, out of the window of tolerance, we'd be looking at things like, you know, meditations, mindfulness, yoga, you know, and be discussing with the client what suits them, what fits into their lifestyle. So there's lots of psychoeducation that goes on as well. And clients, you know, can often work this out for themselves. You know, they can try things out. They can find out what works for them. That might be to stop doing things. So in the case of someone with a health anxiety, you know, come off that Instagram, stop following all the Facebook groups, stop Googling various signs and symptoms. So for some clients, it's about not doing things, but then we have to think about, well, what you're going to do with all that time you've just created by not spending every evening doing that. And for some clients, you know, what are they going to kind of put into their lives? You know, some mindfulness, meditations, yoga, walking, connecting more with nature.
Yeah, so because the way that the world is, we're all on technology. I mean, even this discussion is on technology.
Yeah.
But that's right. Even for myself personally, when I put all of the technology away and I just get back to the basics, have real conversations one-on-one, and get out in the fresh air, or just have a day of reading, my entire body just relaxes and I'm more in the moment, and I can even think more clearly. So yeah, that's really essential from my experience.
Yeah.
Is there a point where for some people the traumatic memory is so far in the past that there's no way that can be healed? So say if I'm 59 and I've had childhood trauma. And then I just realized now by watching a video that, hey, I can actually get treatment for this because I have this debilitating anxiety. I've had it my whole life. I've had broken relationships. I've had whatever the symptoms are. Would that case be fixable? Or is that too...
That's mostly my caseload.
Oh, wow. Okay.
So no, it's never too late. And, you know, so there's even, you know, there's even protocols and trainers and people who focus on pre-verbal trauma.
It is fascinating. And I think a lot of the side effects and a lot of the health conditions that we have and the manifestations are a result of trapped trauma that we haven't released and we haven't been aware of. Like even just chronic stress, you know.
Yeah. But I work with people, it's not unusual for them to tell me they have IBS.
Yeah.
You know, they have digestive problems, and then I'm working with them, you know, that kind of improves. We know from the ACE study, the Adverse Childhood Experiences study, those people, children who have, you know, 4 or more ACEs, you know, have increased risk of chronic health conditions in adulthood. Your area, when you have clients with tinnitus and are distressed with their tinnitus, you've said that some of them have had traumatic events.
Yes.
That's kind of an antecedent to the tinnitus or has exacerbated the tinnitus. What kind of trauma event are kind of typical?
I think it's really interesting because in people that I see with tinnitus, there is quite a strong pattern, not with everyone, but there is a thread with a lot of people where the tinnitus will actually manifest a couple of months after a traumatic experience in their lives. So it's an emotional trauma. So it could be a physical trauma, like a car accident, like you said, or it could be a divorce, or it could be, you know, having a major bust up with a family member or someone that a loved one, or anything that really they are stuck with emotionally. So that whenever they think, it's like in the moment, they can't actually cope with it. It's this major grief. So it's a definite emotional wave. So it's far surpassed general anxiety or sadness. It would be classified as a trauma. And so, as you were saying, some people, when they experience the trauma, they can naturally, with time and with support, they can naturally process that over months, or, you know, in some cases weeks is very rare, but months, and they're not going to have the tinnitus manifest. And then it also depends on how many stresses are in their life at the time. So there's an accumulative effect. So say things aren't going well at work, or they've got this job which is just chronically stressful, and maybe they're just constantly juggling with work, with kids. It's just a bunch of stress, and then bang, something major happens, and then it's like they just crack. And it's a coping mechanism. They don't actually have a coping mechanism at the time. Stress is a major factor in chronic tinnitus. And so whenever I see someone with trauma, and as I said, I see that quite a lot, then I always look at, okay, how can we actually tap into that in a safe way? How can we actually treat that? Because that stuff is actually causing that chronic stress cycle as well. Well, it's influencing it anyway. We don't know if it's, 100% causing it. There are so many other variables, but definitely there's an influencing factor. What's your recommendation for finding a really good practitioner?
Good question. I would always go to the country's association. So EMDR UK, EMDR Ireland, there'll be an EMDR Australia, I think. Yeah.
So thank you so much for your time. It's been brilliant, honestly. Yeah, just amazing.
Yeah, no, it's lifelong learning, isn't it? And growing and developing and rediscovering who you are as you come through those experiences.
Very true.
Yeah.
We're always updating ourselves.
Yeah.
And hopefully in a healthy way.
Hopefully we try. Yeah.